Well, there's been more information coming from the United States this week about what appears to be a new variant of the COVID-19 virus. As you know, we have the original variant, what I suppose was here in the first wave, then the variant that was first identified in our country. Now seems that there's another variant that's been identified in New York. Aisha Abdool Karim is the senior health reporter at the Bhekisisa Centre for Health Journalism. Aisha, good afternoon to you. What do we actually know about this new variant at the moment?
So, what we know is that it was identified in New York City, and it seems to share a common mutation with the variant that we also have circulating here, which is also, and it's also common in the variant that emerged in Brazil. And essentially, this mutation or change that we're seeing across multiple variants emerging around the world is allowing the virus to kind of evade the original immune system response that was formed against the original version of the virus in circulation. So it's kind of expected because, as has been previously discussed, the variants are a result of the virus trying to survive. And it's not something that was unexpected. We knew that the virus would mutate over time. And so, what is interesting to see is that these common mutations are basically serving the same purpose, which is they allow the virus to evade antibodies. And the B526 variant, which was identified in New York, the new one, also has another mutation which allows it to sort of bind more tightly to your cells. So that is also like a common trait, if not the same exact mutation. It is something that we're seeing commonly in the variants where they're able to attach themselves better to human cells, which is going to allow them to spread faster and wider.
Okay, I mean, this is the kind of thing that is very complicated and very scary all at the same time. So let's try and sort of deal with the complications first. So it's similar to the variant identified here, but it's not exactly the same. And the similarity, if I've understood you correctly, is that it is as transmissible. It is an attempt by the virus to make itself more transmissible and better able to jump from person to person. That's the similarity.
So that's one similarity. And that purpose is actually not in terms of the change. So it's not an identical change. So it's not like if you took the variant that's in New York and if you took the variant that's circulating in South Africa, structurally, there are some differences. And because of the sequencing, which is where you kind of unravel how the variant is composed, you figure out what's different in this version. So if you're going to look at that kind of unraveling, there is one common occurrence in the version that we have here in South Africa and the version that is in New York, and that's at the site. It's called it's the binding site. So that's basically the point at which the virus is attaching. But what it's doing is that mutation is allowing the structure to change in such a way that it can evade antibodies, which is what your body uses to fight off the virus. So the structural change that we're seeing that's similar in South Africa, Brazil, and New York is actually, it's not about how it's binding to your cells, but it's about how it's evading the antibodies that your immune system creates to fight the virus.
Okay, I mean, this is all happening very, very quickly. So do we know if you've had the variant, I'm going to keep using this phrase, the variant that was first discovered here, would that give you any immunity to the variant that's now being discovered in New York, or is it too early to say?
I think at this point there's limited information on specifically the variant in New York, but also the variant that we have locally. Essentially, to understand these long-term issues that these variants are creating, we really need to do a lot more sequencing of people's viral samples, and we need to study the variants more. So they've only done a handful of sequences in the US. We've done, I think, a couple hundred or at least 1,000 locally, whereas the UK, which has identified its own variant, has done thousands of sequences. And so that's why you'll find that we have a lot more information, and we get faster information out of the United Kingdom about, the transmissibility of their variant as opposed to the one that we're seeing in South Africa because we just have too many questions still to answer. What we can say at this point is that we do know that if you've been infected with the original version of the virus that was dominant in the country, it is not offering sufficient protection, which means you can get reinfected with the new variant. It's unclear if you get infected with one variant, if that offers any protection against another variant. That's still something we need to look at and understand about the different variants that are circulating around the world.
I mean, Aisha, the heartbreak, of course, is if this would mean that the new vaccine doses due to arrive in South Africa tomorrow suddenly wouldn't work against this variant, if this new variant, the new variant, were to come here. And again, I presume it's just too soon to say.
So I think what's important to note is the Johnson and Johnson vaccine, which is the vaccine that we're currently receiving in the country, has proven to have a very high protection level against the variant. And why it's important that to note the Johnson and Johnson one specifically is because it has the highest efficacy specifically in South Africa, which is a 57% protection against infection of the new variant that's circulating in the country. And that's important because of all the variants that we've seen emerging around the world, South Africa's happens to have the most number of mutations in an important part of the virus. So that's the part at which it's attaching to cells. So because we have so many mutations that allow our variant to spread faster and also evade antibodies, if a vaccine has shown high efficacy locally, there's a good chance that it's going to offer protection against other variants as well because of those commonalities in where the changes are occurring, even though the variants are different. And then the other thing that makes Johnson and Johnson what I would call a very optimistic vaccine to roll out locally is that at this point it is one dose only, which means you need to go for one injection and it's offering over 50% protection, which means that if later on we need to give someone a second dose as a booster, or if they make a custom vaccine against the variant, we could see much higher protection levels after a second injection, which would be easier to sort of roll out because instead of a third injection, it's the second shot that we need to give people. So even though the variants are cause for concern, I think there is also a lot of promise, particularly in the rollout of Johnson and Johnson's vaccine locally.
Okay, I mean, that's good news a Friday afternoon, Aisha. We could do with it when it comes to COVID-19. So as I understand viruses, and man, you've helped educate a lot of us about viruses over the last year, but they mutate like this. This is what viruses do. Sometimes they go the route of becoming less harmful to human beings because they want to survive, and so they want to be transmissible, and so the longer the less impact they have on the host, the human being in this case, the longer the virus is able to live and be transmitted. Sometimes you have other viruses, not coronaviruses, but a hemorrhagic fever like Ebola is a good example, where it has such extreme impact on the host that the virus itself can't actually transmit itself very effectively because it kills the host. We kind of don't know which way the coronavirus is going yet.
So I think in terms of the variants that we currently have, South Africa is a great example of being able to capture data about the variant in real time because we identified our variant very early on, and we noticed how it contributed to the second wave of infections, which luckily we've now passed the worst of. And so what we've seen is that when we looked at the infections and the cases that we saw during the second wave when compared to the first wave, even though there was a higher number of hospitalizations and sadly a higher number of people passing away from severe cases of COVID-19, when you actually put it into perspective, why we were seeing that jump was because of the increased transmissibility. So because more people were getting infected with the variant, because it's engineered itself to be able to spread better from person to person, we were seeing more cases. And so even though a large proportion of cases are mild, when overall you see a higher number of cases, you're also likely to see a higher number of severe cases. And so we have that information, sort of initial data from South Africa taken from our second wave, where we're assuming that the variant that we're seeing at the moment is not more severe, it is more transmissible. I know that there is some data about other variants in other countries where they do believe that their variants have become more severe. But at this point, that's not something that we think is the case locally.
Aisha Abdool Karim, thanks very much indeed. Really do appreciate it.